Your trauma patient's blood pressure was normal just 2 minutes ago, and now it's 84/50. They look worse, the monitor is alarming, and everyone in the back of that ambulance is looking at you. There's a tiny pause in moments like this. Your brain now has to work out what changed. What does this all now mean? What now matters most, and what everybody should do next? If this is the first time you've considered what comes next, your thinking is starting from zero at the exact moment the pressure is the highest. But what if you had already made the decision? You cannot predict the future, but the thing you need to understand is you do not need to predict the future. You just need to plan for it. I'm going to show you the exact framework we teach all of our students in the Loud and Clear Fellowship program. A simple 4-part framework you can use on your next call to shorten that pause and help your crew stay ahead of a crashing patient. It's called the if-then framework. So as we get into this, every call has a current and a future state. So you know what is happening to the patient right now, but there are several things that could happen next. For example, the patient could improve, a single vital sign could change, or it could become a shit show. I mean, a resuscitation. You cannot know which one of these your patient will take, but the common ways that patients deteriorate are not a mystery. The problem is that many clinicians wait for the patient to change before deciding what they will do next. The abnormality appears, and only then do they start building a plan in their mind. Now they are reassessing the patient, interpreting new information, remembering the protocol, ranking priorities, talking to their partner, and performing interventions all at once. The if-then framework moves some of that thinking earlier when you still have the time and mental bandwidth to deal with it. It does not replace your reassessment or clinical judgment, but it moves some of the predictable thinking into a calmer moment so that you do not have to build every decision from scratch. I learned this lesson actually early in my emergency medicine residency. I was a second-year resident in charge of a big 12-bed patient zone for the first time, and I was struggling to keep up. And it wasn't until a senior resident took me aside and told me, you need to focus on your if-thens. So picture this. I go see a patient, and let's say it's a chest pain patient. I leave the room, I put a bunch of orders in to try to answer the question of what might be going on with that patient. And one of those orders might be a troponin. And then after that, I'm going to go see 4, 5, 6 more patients while continuing to also manage everybody else I've already seen. And at some point, I eventually make it back to the computer, and that troponin has resulted. Now, it's either negative or positive. If the first time you ask, what will I do with this result, is after the result appears, you have just created a brand new decision in the middle of an already overloaded environment. And this is when I learned the distinction. Ordering a test is not a plan. The plan is knowing what you will do when the test results. If it is negative, then what? If it's positive, then what? Or what other information might change that decision-making process? Because you have already considered the likely branches, you can recognize the result and move without starting your thinking from zero. The back of an ambulance can work the same way, except the future can arrive a lot faster, and you're not relying on diagnostic tests outside of maybe a glucometer and an EKG, but instead you're looking for patient changes. So let me show you what a useful if-then plan actually sounds like on an EMS call. And importantly, it is more than just saying, if they get worse, we will do something. There are actually 4 parts, so let's go through them. First, you're going to identify the likely change, or what I call the what ifs. Choose 2 or 3 changes that are most likely to happen or most dangerous to miss. Second, name your triggers. These are your ifs. It's not simple enough to identify what might likely change. What you need to do is make it specific and observable so you know exactly what you're looking out for and what is going to trigger you to act next. What finding will tell everybody that this situation has actually really changed? Third, you're going to respond. This is your then. Now, again, it's not enough to say, I'm going to go do something when this changes. But if the trigger appears, you need to identify what are your priorities. What is your single most important priority? What's going to happen first? And then rank what needs to happen next. What can maybe happen at the same time if you have enough hands? Or what can wait for the next step once you've finished that first priority? Fourth is your team. We need to share and tell the team what's going on. Say the plan out loud. Decide who will do what and what can be prepared for now so it's right where you need it when you're ready to act. This is important. We need to create a shared mental model with our crew. We may have a great plan in our head, but if we don't share that with our team, the moment that change occurs, we may be ready to act, but the rest of our team is still going to be playing catch up. So our delegation is still going to be left in that catch up mode. We need to share the mental model with the entire team so we can act as a unit if it occurs. So in short, you're going to identify the what ifs, what can change. You're going to then get specific on the trigger of what changes, your if. You're then going to respond, and you're going to share that mental model with the team. Let's put this into a real call. So let's say you're transporting a trauma patient. And let's say maybe they got some, chest wall trauma, and maybe their heart rate's elevated, but they got a normal blood pressure. So next, we need to identify our ifs. What could potentially change in this patient's course? So first, maybe they develop, say, some respiratory distress. Or maybe their perfusion goes to crap, their blood pressure tanks, or they develop some altered mental status. Or maybe it turns into a full-blown traumatic arrest. Once we've identified our ifs, we now need to identify our thens. You do not need 15 branches here. Just pick the 2 or 3 that are most likely or most dangerous to miss. Now, there's more than likely more than one response that you're going to want to take to any specific trigger. So choose the responses and prioritize them in order of importance. Focus on one response at a time. The exact steps depend on the patient, your protocols, and what you can actually do in the back of your ambulance. The point is to decide your priorities before the trigger appears and do them in order of importance. For this patient, that might include reassessing for any life threats that you might have missed, or giving blood or TXA if you have access to it. Or it might be decompressing the chest and then probably updating the hospital on the change as well. Again, these priorities may vary by patient and system, but the importance is figure out what your priorities are, communicate them to the team, and then act on the first most important one at a time. Do not leave this as an unranked list. Decide what happens first, what can happen simultaneously if you have extra hands, and what can actually wait. Then, again, tell your crew, share your mental model. Who is doing what? Where is the equipment? What needs to be prepared now? And what can your partner begin without waiting for another instruction? That short conversation changes what happens next with our trauma patient. Because imagine that the next blood pressure is 84 systolic and the patient has become pale and less responsive. The finding is no longer a surprise that forces everyone to wait while one person invents the next move. The trigger has appeared and the priorities are already shared with the team, so the team can begin moving together while the lead clinician continues to evaluate the patient and lead the call. You moved some of that predictable thinking out of the highest pressure moment. And this works on almost every call. Once you start looking for if-then decisions, you will see them everywhere. Say you have a STEMI patient. So obviously you're going to treat, ACS per your protocol. But then think to yourself, what if this STEMI patient suddenly becomes hypotensive? What am I going to do? Maybe it's going to be, I'm going to start out trying to fluid bolus, but if that doesn't work, then I'm going to move depressors. Or what if they arrest? Then I'm going to need to be prepared to perform an ACLS. Where are my pads? Are they ready and immediately accessible? Where's my airway equipment? Where's my BVM? Does my team know what their job is going to be if that happens? What about an anaphylaxis patient? So obviously we're going to give them some epi and we're going to observe what happens. Maybe they improve. Great. If they do, then we're going to, observe them for any sort of rebound. And if no rebound, they're likely at the end of the day going to be able to go home from the hospital. But what if there's no improvement? What is our next step going to be? Is it going to be repeat epinephrine? Are there any next actions we may want to take? Different calls, same thinking. If this happens, then we do this. Here's the point I want you to remember. Do not meet the future unprepared. You do not need to predict the future. You need to plan for it. You will never anticipate every possibility, and you should not try to. Choose the changes that are most likely or most dangerous to miss. Name the specific trigger that is going to let you know that has occurred, and then rank your responses to that change. And don't forget to share that plan with your entire team. The goal is to avoid meeting a predictable emergency with an unprepared mind. On your next shift, try this with every patient. Name at least 2 realistic ways the patient's condition could change. Decide what specific finding would trigger action, choose your first priority, and then say the plan out loud to your team, your partner, so everybody understands and is on the same shared mental model. Understanding this framework is easy, but using it naturally when everything around you changes and everybody looks to you for what to do, that takes practice. Inside the Loud and Clear Fellowship, we work through real cases, challenge your decisions, and give you feedback until this kind of thinking becomes just part of how you operate. If you want to practice with us, click the link in the description to learn more about the fellowship. If you want more frameworks just like this one, make sure you like and subscribe to the channel because we're going to be sharing a lot more of these.